Satanshu Mathur is going to speak to us on IOL explantation made easy. Is, as we all know, from which part of India he belongs to. So the next 7 minutes are yours.
Thank
Sir,
you,
please
thank
go.
you, Anurag, chairpersons. Match is going interesting, so we have to leave early. So everybody. So good afternoon, everybody. After lunch, this thing, the IOL explantation has become very important nowadays. In our, when we have started practice, patient has having 3 or 4 diopter syndicate power. It was not so important for us. But stop case, hello. But it was not so important for us. We used to give glasses. But now, scenery has changed. Everybody wants 6 by 6. So things have changed. So we have to change our mindset also. There are many indications for IOL exchange. These are indications for IOL exchange. Wrong IOL power calculation, unhappy patient, especially after the multifocal and trifocal, poor positioning of the lens because of insufficient capsule support, damage to IOL optic haptic. That can be the chances of and IOL exchange. This is a case, very clean case operated by one of my colleagues in neighboring city who came to me with a +4 diopter refractor and other eye was 6 by 6. So patient was not happy. I have also advised him to use the glasses, but he was not happy. So I thought he has came from the other doctor to me, he will came from me to other doctor. So why can't we do the same thing which is required? You can have a piggyback lens in this also, but at that time we were not doing the piggyback. So we have tried to do the explantation of the lens with new IOL. So it was case operated very recently. So there was no adhesions. We could easily take out the lens from the bag into the anterior chamber. You have to use copious amount of viscoelastic because you have to protect the posterior capsule and the endothelium both. So in this case, there was no difficulty because case was very good operated by, it was his bad luck that power wrongly calculated. And most of the time the wrong power calculation happens when there is a patient either high myopic or high hypermetropic. So once the lens is in the antechamber, we are injecting viscoelastic to protect. This is a simple cut, scissor cutter, lens cutter forceps, scissor. Easily available in market, made by Indian companies, not very costly. You can take out the lens in many ways. Our main aim is not to enlarge the incision. Incision should be 2.2 or 2.8 millimeter. This is the 2.2 millimeter incision was there, from which the scissor has gone. We have rotated the lens and we are going to make a triangle cut. You can make triangle cut, you can make single cut. We show on the 3 videos, different types of cut you can make and take it out the lens. So we are rotating. When initially we used to make this triangle, now we are simple giving a single cut and lens is coming out. Aim is that this scissor, when scissor is entering, it is 2.2 millimeter incision. So it is cutting again and triangle is formed. Now we are enlarging incision to 2.8 millimeter to expand the lens. So we have stitch test surgery, and that's why this lens cutting scissors are used. First, this small part is removed. Now the triangle part is saved. Rotate it. Again, injective viscoelastic. Hold the lens and pull it out. This serrated forceps, simple forceps available in every OT. Just hold it and take it out the nucleus by rotation. So you can remove this easily. So I am just cutting it short because lens implantation is not so important. Next video chala jana. Next. Ise band kar do. So this was the one. Second is the case, another indication of IOL explantation, and that is number 2. Number 2, upar wala. Number 2. This is another indication, opaque lens. I don't know, for last 2 or 3 years, we are getting so many these opaque lenses operated by our senior surgeons. Or you must be also having, this patient has vision 6 by 36, patient was not happy. So we have no option but to remove the lens. This was operated almost 20 years back. Lot of adhesions are there. You can see when we remove the lens, you can see the capsule also. Lot of adhesions are there. So, we have operated 2 cases only till now, but many cases are lined. The patient has good vision, so we are not operating. We are waiting till the vision deteriorate. You just keep removing the adhesion by viscoelastic. As you see, the posterior capsule also very thickly opacification. Rotate the lens gradually. Again bring into the antechamber. Now, once the lens is antechamber, the work is very easy. So you have to protect the posterior capsule when explanting the lens from the bag. Now it is, in this case, we are giving a scaffold lens before removing it. So this is another way that you can put the scaffold lens before cutting the lens, because scissor might touch the posterior capsule. So you can put the scaffold lens first in place, and then you can expand the lens. Now, we are holding the lens from the other side port, just holding the lens with a dialer and cutting the lens. A single cut. In this case, we are making a single cut and just hold the optic haptic junction, and lens will come out by simple rotation by 2.8 millimeter incision. So, in this case, third case, so this is the lens removed. Now you can do, lens is already implanted, third case. This is another indication which is very common now in Indian hydrophobic lens, cut of the optic or haptic. This lens is implanted, case is successfully done. You see there is a breakage of haptic. We can't keep this lens inside the eye. Previously we used to keep it there. We were very afraid of taking out the lens, but dislocation of the lens is very common, and other doctor can pull your leg. So this is broken haptic at the optic junction. So you have no option but to remove this haptic first. And then this is hydrophobic lens. So it is not easy to cut by the scissor. So we are cutting, holding with the side port with the other dialer and cutting it through and through. Because it's hydrophobic lens, so it takes some time in cutting. And now the 2 pieces can be removed by the simple serrated forceps. You can do scaffold lens here, you can do lens implantation later on. So there are many techniques to remove the IOL. This is a scissor cutting is the one thing. Nowadays we are starting using the explantation of lens, not by the scissor, by our cartridge, which we are using snare technique. So we are cutting the lens by the snare, which was used long time back by our friends. Now we are using IOL cutting. So next conference I will show you that video. So we are cutting it to 3 parts, and then we can remove, you can make, because I am a SICS surgeon, also break the nucleus in the antechamber, 2 or 3 parts. So we can cut 2 or 3 parts and remove from the 2.8 millimeter incision. So next time we will show you with another video with a snare cutting technique. This. Thank you. I'm well in time, I think.
Yes, you have saved us big on time. So any particular reason why you're not using a proper forceps to fix the IOL and the ballpoint dialer?
That is blend dialer.
There's a reason why I'm asking this question to you, sir. The reason why I'm asking this question to you is because particularly when you're cutting the hydrophobics, which are essentially harder materials in the fillix, and even the calcified IOLs make the IOLs. So when you're attempting to cut them, at times they just slip, and when they slip, they tumble. So one fragment faces the PC, the other fragment faces the endothelium. So
Anurag, actually we are holding the lens, we are the side port. It is only or not in large, it's very small. So forceps when go inside, you have to make big incision. But we are using nowadays with the micro forceps.
Yes.
We are holding with the micro forceps nowadays. These are all videos. We are holding with the micro forceps. But in hydrophilic lens, there is no use, no need to hold it. It easily cut, because we have to cut only up to the center part, or not up to center, even up to the 1/3 of the upper part. Then you can take it out. But hydrophilic lens, definitely you need a support to hold it. You are very right. We are using micro forceps nowadays.
yeah, the microforceps actually work very well for that purpose. The other question I wanted to ask you, sir, was since you are levering it completely out of the bag and keeping it in the AC, it's something I don't do. I actually tilt it and just keep half of it on the iris and half is still inside the bag when I cut it. Since you are placing it whole in the anterior chamber, are these patients operated under topical or do you give a peribulbar block?
No, as practitioner, I will do the under the anesthesia because we don't know the posterior capsule what happening there. We need vitrectomy, we need something else because sometimes you posterior capsule not with, especially the second case when the opaque lens was there, we are not sure what is happening. That's why I implanted a sulcal fish 3-piece lens you must have seen.
Yes, I have seen.
So we don't know what is going to happen. But the first case you can do in a topical. There is a very simple case.
Yeah, there's again a reason why I was asking that because the bulky haptics if rest on the ciliary body and if you're moving them while cutting them, they will move when you're cutting them. So sometimes under topical the patient actually screams in pain. So a peribulbar would be a better idea. Thank you so much, sir.
Thank you.
Any other
Thank you.
questions?